And welcome to United TV. This is our Bariatric Friday, January 12th, 2024. We are going to have Dr. Irgau joining us. This is the first episode of the cycle. I'm going to let Dr. Irgau in. All right. Good afternoon again. My name is Kemal Erkan. I'm the chairman of American Surgery Center. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Glad to be back for our favorite show, Bariatric Friday.
All right. So, Dr. Irgau, we have two different things today. One is I want to start with our survey questions, and then see if we can actually, let me see if I can bring them up. So, all right, so these are one, two. So this one's first one. Okay, so I'm starting with the first one, and it's going to be on our third screen. So the idea here is for us to kind of just have enough answers on these surveys. So I did this for our 2 p.m. Event, and then as I was doing it, I liked the interaction that we were getting from different groups. And also a lot of things that you and I, we talk, we try to provide more education, more information, more knowledge, and knowing who we deal with, not just patients, but overall the society itself. This is giving us a good background on the issues. We are not running this based on just one specific group. We are not running this for it's not my followers, so it's being promoted in the United States, and it's not promoted for people with morbid obesity only. It's promoted for everyone, so I cannot separate. The only filter I have is 18 years as this floor, and the rest, there's no other restrictions other than for those who are in the United States. So the first question that we have is about how people actually see the obesity, and I'm going to actually read this for you, and then I don't know how much you can kind of see from the third screen. Question number one, which weight loss method do you find most effective for morbid obesity? So, and you and I, we are not surprised with this answer because 76% of the people, they think that diet and exercise is the most effective way. So, and then bariatric surgery was the second one with 18%, and there's medication, which is 6%. So we talk about these issues because we know that many people don't know that bariatric surgery is the most effective tool to fight morbid obesity. And this survey shows us that most people, they still don't know this is the case. Now, of course, we have limitations, so we have to kind of make some adjustments when we are processing these results. But it's interesting how people think that they can lose weight with diet and exercise. And that's maybe true for you and I and maybe Sean. But those who are chronically ill with morbid obesity, that's not the case. And that's why I think it's important for us to have these sessions. And I know we'll have a different sessions to discuss these results, but I just want to kind of put these out there. And then if you want to add anything before I go to the second question.
Yeah, it really confirms what we already know, and that there is a bias against bariatric surgery, right? I mean, if you had placed the same question about cancer treatment, you know whether surgery was more effective to remove a colon cancer as opposed to a medication, what would the answer be, right? The vast majority of people would say, go to the surgeon, right? Get it out. So there is really a bias toward obesity because not only there is obviously a misunderstanding or not enough knowledge about bariatric surgery, but there is a bias towards what obesity is. Whether it's a disease or not, people still think it's a self-inflicted condition that people should be able to address, just like the length of their hair or the length of their nails. You know what I'm saying? So that is the bottom line, really, and it reinforces that, and it also makes it hugely important for us to continue doing these sessions, really, to try to divulge the knowledge of bariatric surgery as a very effective, very often life-saving and extremely important medical treatment.
Definitely. Now, I'm going to go to our second question, since we are going to discuss these later on anyway. The second was, how often do you discuss the importance of obesity awareness in your community? So regularly is 22%, occasionally 17%, and rarely is 61%. So that's, again, like it's telling us, kind of confirming what we already know. It's kind of interesting that people don't talk about it, because for the same reasons, maybe they don't think this is an important issue. It's a disease. All those things are all together. So it's interesting that people don't talk about it.
Yes, yes. I mean that's there is some irony in that, Kemal, isn't there? Because of all the diseases that one could talk about, obesity is probably the most declared one, the most public, right? You walk around, if you have obesity, people will know because they see, right? It's not so for diabetes, it's not so for cancer, and yet
Right.
people will talk about diabetes and cancer, but the issue of obesity is hush hush. Again, the stigma of obesity, right? And that is what we have to really push through and win over, Kemal, to get people to really understand that this is an extremely serious health issue that should be talked about and addressed appropriately.
Absolutely. So then very quickly, our question number 3, which is, again, these are all going in one order. The question number 3 is, what's the biggest challenge you have faced in your weight loss journey? Staying motivated is 40%, that's number 1. Dealing with cravings, 38%, that's number 2. Finding time to exercise is about 18%. And social stigma, which is surprising, it's only 4%. So for the staying motivated, 40%, that's number 1. The reason we do Bariatric Friday is for those who are having that problem, who are having difficulties to stay motivated. So hopefully, we are supporting those. But anything you would like to add to this?
Yes, it's interesting, right? That people find this, struggling with cravings and staying motivated as really big obstacles, but also those really are the heart of the matter, right? Because you are fighting a biology that drives you to eat despite the fact that you have enough energy, enough food inside you when you're struggling with obesity, right? The normal, it's like, if we talk about a car that has a full tank of gas, right? The indicator tells you it's full because it has full gas, right? It never says it's empty. And yet we're acting as if we have all the gas inside us, and yet the indicator says empty all the time. So that is the biology that we're fighting. And that's precisely why people continue to gain weight despite their best efforts.
Right. So I think this is, these are good exercise for us to kind of see how people are taking these and what their opinion is, right? So because knowing we are not only just fighting the disease, but we are also fighting the knowledge of what this disease is in the society, it's making it more challenging. So that's why repeating these events and explaining people that bariatric surgery is the most efficient tool to fight morbid obesity. Bariatric surgery is not the tool for me or for Dr. Irgau or for Sean Donegan. However, if you are someone who's dealing with morbid obesity, this is the right place to be, because we are going to talk about different surgery types, bariatric surgery types. And Dr. Irgau, we can start with bypass if you would like.
Absolutely. So all bariatric surgeries, as we've said in the past, involve some type of rearrangement or change of the digestive tract. Okay, the classic, probably the well-established procedure that has been going on really starting from the 1950s probably is to different variation is probably the gastric bypass, right? And for many years, we've held it as a gold standard of obesity surgery, of bariatric surgery. With gastric bypass, what we essentially do is we make the stomach very, very small. We cut the stomach so that one portion of the stomach is really the size of an egg or the size of a fist, if you will. And then we rearrange the small intestine so that a portion of the intestine is brought up and connected with this little stomach. And what we create in this situation, Kemal, is we create a little stomach that receives the food. And then the food, instead of entering the early intestine where most of the digestive process occurs, it actually bypasses that portion and enters the lower portion of the small intestine. In this way, the person will be eating very little because the stomach that receives the food is small, but whatever food has been received will also be processed very slowly and not completely reabsorbed. So the end result will be our body will be receiving much less of whatever food has been eaten, right? So that's really the classic procedure, the standard procedure that we performed for many, many years. In fact, our practice, CHRIAS, introduced the laparoscopic method of this procedure early in the 2000s. I believe we started our first procedure in 2001. And for many years, until the advent of the gastric sleeve, that's the procedure that we perform. We performed probably 600-700 gastric bypasses a year for many years. Still, we perform gastric bypass. Still, gastric bypass is a very important component of the procedures that we offer. The biggest advantage of gastric bypass probably is the fact that by dividing the stomach high up, you're really preventing any acid from reaching the food pipe. So the chances of getting heartburn, irritation of the food pipe are much less. Gastric bypass still has an advantage over the sleeve, for instance, in terms of its ability to control blood sugar, so diabetes. And obviously, in terms of weight loss, probably there isn't a huge difference between the gastric sleeve and the gastric bypass, Kemal. So that by itself should never be the number one criteria for choosing the gastric bypass over the sleeve. Importantly, we have to realize that the long-term implications of gastric bypass, including the fact that by not reabsorbing nutrients, you can actually expose yourself to vitamin deficiency in the long term, which can lead to hair loss, which can lead to bone weakening, which can lead to poor healing, even nerve damage. These are real problems. So anybody who has had gastric bypass must be taking vitamins in the long term and have blood work on a regular basis to make sure that that's not occurring. The possibility of forming ulcers at the connection between the intestine of the stomach is also real, particularly if the person takes certain medications known as NSAIDs, which are aspirin or aspirin-like medications. Of course, smoking is an absolutely no after gastric bypass because that can lead to ulceration as well. So gastric bypass, a very important procedure that we offer, that we've been offering for many, many years, is still an important procedure.
So basically, if someone who's probably over 50 with certain conditions like diabetes, heartburn, bypass perhaps is the number one option to go since they're already up there. So I say 50, I have to be careful because I'm getting there. So let's say 55. So I'll push it by 5 years. So for those who are over 50 with these comorbidities, that would be the number one choice. But the one that we do 75 to 77% of the time is gastric sleeve. And for that, actually, just from the numbers, we kind of see that's our kind of number one procedure to go. Let's hear you explaining that for those who may be considering that gastric sleeve.
Absolutely. So, Kemal, the point you made about age is an important one, right? Because what you're mentioning really is that the long-term implications of rerouting the intestine have to be considered, right? So if somebody is in their mid-20s and they have gastric bypass, the long-term implications of rerouting the intestine, which include problems with absorption of nutrients, potential for the intestine to twist and create a bowel blockage, formation of ulcers. All those will be valid for that person. If that person were to live another 60 years after that, those problems will be there for 60 years. So you're absolutely right. Considering the age of the person is also important when you're choosing a bariatric procedure. So you're much more, much less likely, to have these long-term problems if you're already in your 50s or 60s, shorter period of time compared to somebody who's a lot younger. So somebody who's a lot younger, you don't want to expose them to these problems, for such a long period of time, which means you may choose a procedure like the gastric sleeve, which is still a very powerful procedure, but it does not involve the rerouting of the intestine. And this is a very important concept to understand. So yes, we're working on the digestive tract on both procedures, the gastric bypass and the sleeve, but there is a very important difference. When we're doing the sleeve gastrectomy, we're just altering the stomach. When we do gastric bypass, we're also altering the intestine, and that is where the major difference is. So with the gastric sleeve, all we're doing is reshaping the stomach. The stomach looks like a watermelon, looks like a football, right, in its original configuration. When we're done, when we're cutting with it with the sleeve gastrectomy, the shape of the stomach looks like that of a banana. The portion of the stomach that made it look so big is actually removed completely. So the gastric sleeve only involves reshaping of the stomach. The intestine is left intact. Okay. Now, what are the advantages of the gastric sleeve? As I said, you're not rerouting the intestine. So the problems of malnutrition, to the extent that you see with gastric bypass, you don't have them. You don't have the issue of the intestine twisting because you have not rerouted the intestine. You don't have the issue of ulcer formation because you have not reconnected the intestine with the stomach. So those long-term problems are not there, right? In terms of weight loss, I think if you look at the studies, Kamal, there is actually a fairly close results between the two in terms of long-term weight loss between the sleeve and the gastric bypass. The gastric bypass is a little bit stronger when it comes to controlling diabetes. There's no question about that. But we shouldn't forget that the sleeve is also a very important metabolic procedure that has powerful effects on controlling diabetes as well. Perhaps the one negative of the sleeve could be the fact that some people develop heartburn or acid reflux after the sleeve gastrectomy, requiring medications, and in very rare events, conversion of the sleeve to gastric bypass. Well, let's talk about this conversion, for instance, Kamal. When I explain the difference between these procedures to people, I talk about the gastric bypass as a final stop procedure. And I talk about the sleeve as a midway procedure, meaning that if there are problems in the future, if changes need to be made in the future, you can always rescue the sleeve gastrectomy because you can change it into gastric bypass, but you cannot change the gastric bypass to a sleeve. Once the gastric bypass is done, it's done. There are very few avenues for you to rearrange things if that is needed. With the gastric sleeve, for instance, few patients who've had very significant heartburn after the gastric sleeve, we went ahead and switched them to gastric bypass. So by itself, just going to gastric bypass because you're fearful of heartburn does not make much sense given the long-term implications of gastric bypass. So the sleeve essentially is a less invasive procedure, less changes in the digestive tract, but still a very powerful procedure when it comes to weight loss. And it's no surprise, Kamal, that I believe it's 75% of our procedures are now sleeve, do you think?
I want to say between like 75 to 77% right now.
So the vast majority of people actually choose the sleeve, and very often people will have come with their mind made up, requesting the sleeve as their procedure of choice. And in the vast majority of cases, really, there is no reason to, to negate that to people who want the sleeve. There are very, very few instances in which the sleeve is not appropriate for the vast majority of people.
Sure. So, in simple terms, sleep is our like number one to go if you don't have the age and other comorbidity issues. So that's kind of like
Absolutely. Absolutely. I mean, I think, the default procedure for the vast majority of people is to sleep again, because you are not really making changes that will have implications long term that could negatively affect their health, right? I mean, you're taking care of a health problem and you don't want to necessarily create other health problems in the process, or at least you want to create as little problems as possible. And the sleep really has been very well established in, fulfilling all those requirements.
now, a couple weeks ago, we did a gastric balloon as one of the methods, not necessarily for morbid obesity, but I think maybe on the lower side of morbid obesity, but more on the higher side of obesity that we choose to go with. I mean, we can briefly mention that since we just did that session, we don't need to go into the details.
Yeah, no, absolutely. So it's the least invasive procedure we have. You're absolutely right. We don't. It's indicated for class 1 and class 2 obesity, and not necessarily for morbid obesity. And it's a procedure that is transient. It's completely reversible, and it's not surgical. In other words, there is no incisions that we make. The balloon is inserted endoscopically, but then after 6 months, it has to be removed. So the indications for the balloon are limited from that point of view, but there is clearly a section of the obesity suffering people who would benefit from the balloon office. And of course, as our practice, as being an all-rounded bariatric practice, does offer the balloon as well.
Sure. Now, we should mention the gastric band, just so that it will be my transition to the revision surgeries. We don't do the band anymore as much as we used to. That used to be the number one procedure 15 years ago. But today, that's not really happening. Anything you would like to actually cover for band?
So when the gastric band was first launched, Kamal, it became very popular. Became popular because it was a procedure that was seen as an alternative to gastric bypass, because these were really the only procedures really available at the time. Gastric bypass, very extensive changes, and then came the band, which is a device that you put around the stomach. No cutting, right? And also it's a device that could be removed. So there was this sense that it was a potentially reversible procedure. And it's still a valid procedure. But the device itself, with its presence in that upper portion of the stomach, in the long term, does create problems, particularly in the quality of life, right? It's not predictable when the person will be able to swallow their food without any difficulty, as opposed to being sick. That really interferes with the quality of life. Secondly, the weight loss itself, there is clearly a difference between the band, the sleeve, and the gastric bypass in terms of weight loss. It's not as powerful a procedure as the sleeve or the gastric bypass when it comes to weight loss. And then there is the added issue of having to do adjustments of the band. Patients have to come to the office from time to time to have their band tightened or loosened, right? And because of that, we actually have seen way more band removals in recent years as opposed to band replacements. And I think the availability of the sleeve as an option to bypass actually has pushed out the band as an other alternative to gastric bypass. So we are seeing a lot more of that. But we still see patients who've had the band for many years and who are doing very well. We still see patients who struggle with the band and have their band removed, and then we move on to a different procedure. And our practice still manages band patients that require adjustment, whether it's removal of the fluid or additional fluid. But as you correctly said, it as a primary procedure, we don't perform it as nowhere near as frequently as we used to in the past.
Sure. Now, the other part of the, I guess, the surgery times, up to now, we are talking about bariatric surgery times. But when it comes to revision, although they are also bariatric surgeries, but we put them under revision surgeries. So starting from band, there are several different ways to have a revision. And one of them would be going from band to sleeve or band to bypass. So can you explain that process, how it works for those who are planning to, let's say if someone had a gastric band 15 years ago, now they're looking for other options, and then sleeve is where they want to go, what process they would have to go through?
So they would have to go through a similar process than, as a person who's starting bariatric surgery, because they really need to be educated about the differences in terms of lifestyle afterwards, right? So, and also go back to the basics again. We have to have a multidisciplinary evaluation, which would include the nutritionist, very often the psychologist, but also making sure that the person is healthy enough to undergo the procedure, so their hearts, their lungs, and everything has to be prepared optimally. Now, it is important to understand that the band itself creates a lot of scar tissue around the stomach, and that scar tissue by itself can be a potential for increasing risks of complications. So what our choice is in our practice, Kemal, is to have the band removed first and let the person heal and the scar tissue mellow a little bit for 2 to 3 months before we take them back to do the revision surgery, for instance, to the sleeve. Now, it is important to sit down and discuss with patients that revision surgery does increase the risk for complications from, initial surgery, just because there was no scar tissue when we first did the procedure, essentially. And scar tissue does not heal as well as virgin tissue that hasn't been operated on. So it's important for them to understand that. And also revision surgeries that is undertaken by experienced surgeons. Because of that, surgery requires knowledge of anatomy, Kemal. And then when there has been previous surgery, that anatomy gets disrupted, and the surgeon has to be experienced enough to understand this disrupted anatomy and perform the procedure, which means that it needs to be performed in very experienced centers. And our practice, having been doing this for many years, does have the experience to do revision surgery, and we do, of course, a lot of revision surgeries as well. So bands, remove them, wait for the healing process to occur. The person will go through the multidisciplinary preparation, and then we can undertake a sleeve gastrectomy after that.
And for those who may be kind of questioning or asking this question, like why someone had a band, now they have to go through another surgery, this is the same thing that we mentioned earlier. If that was that time, that was the best option. Maybe it was the only few options, because sleeve wasn't there until 2010, right, Dr. Ergau?
Absolutely, yes. Yep.
So when there are better techniques and better methods, of course, we are going to improve. So a lot of people, they have a lot of, they benefited from having a gastric band, but those who didn't have other options. So this is why we are saying that you don't have to go with the, like most maybe, not necessarily complicated, but could be most complicated in terms of like bypass. If you're a younger person and you don't have other comorbidities, this would be the time where you can actually look into going from band to gastric sleeve, which we are talking about like 3-4 month period, which doesn't really add as much, right, Dr. Ergau? Because our patients, by the time we prep them, that takes about anywhere from 9 to 12 weeks, because all the clearances and everything that they need to get. Now, there are those who would go from band to bypass. Are the same rules applying in terms of the conditions and criteria that we are choosing for those?
Yes, and it is important to mention in this case, Kemal, that there may be more of a case to go from band to bypass than to go to bypass initially. And the reason for that is, with the presence of the band, many people may have developed irritation of the food pipe that you want to protect from acid in the future. So it is not uncommon to go to bypass as a first choice, after the removal of the band, particularly after you've investigated with endoscopy and assessed the food pipe and so forth. There is a school of thought among some bariatric surgeons which says that if somebody hasn't done very well with the band, they should go automatically to bypass, just because they're thinking, well, the band is more or less a restrictive procedure. So going from one restrictive to another restrictive procedure like the sleeve does not make any sense if the person hasn't succeeded totally. I'm not sure we should adopt this dogma necessarily because everybody is different. So it is important to really have an in-depth conversation with the patient as to why they have struggled, as to why that revision is necessary, and obviously for them to understand the implications of going to sleeve or to bypass. That's a very individual conversation that we have to have with the patients, but obviously both options are there. Again, many patients would rather go to sleeve first as opposed to bypass because of the implications, long-term implications of bypass. But it is our job, obviously, to educate them onto whether that is really appropriate in their particular individual situation.
And even though it's a small, very small percentage, but there are some people, they would have band over bypass, right? Not band over sleep, but band over bypass.
That's correct. That's correct.
That's very little. I have seen it in case there are anyone questioning.
Yeah. So yeah, I mean, not all the surgeons at CHRIAS offer this option, Kemal, but it is offered, which means that for some patients who've had gastric bypass many years ago and are struggling with weight regain, then tightening that portion, that connection between the intestine and the stomach with a band around it is an option. There are many issues that need to be discussed there because having a foreign object around that connection is not something that can be taken lightly, right? So again, when you discuss options for revision, particularly after gastric bypass, there are not very many surgical options, right? But band over bypass is a potential. Again, not all the CHRIAS surgeons offer it, but it is something that in some circumstances could be appropriate and perhaps even work well.
Sure. In terms of other revision surgeries, we do.
So the one procedure we haven't obviously mentioned is the duodenal switch, Kemal. The duodenal switch is the procedure that is not done as commonly, but it is a procedure which is in a way similar to gastric bypass, right? There is clearly a removal of a portion of the stomach, just like the sleeve, but then the stomach is reconnected to a much lower portion of the intestine. And at the end of the procedure, the portion of the intestine that will be processing, digesting, and absorbing nutrients is much, much shorter than the gastric bypass. And the duodenal switch is the procedure that really offers the best in terms of total weight loss in the long term. It is very powerful with diabetes, but also it is the one procedure that will have the most implications long term in terms of vitamin deficiency, perhaps change in bowel activity like diarrhea. So it is offered in our practice. It's not as commonly done as the sleeve or the gastric bypass, but it's an option that we offer, particularly with patients who had the sleeve already and they are struggling to lose all the weight that they wanted. The switch is one option that we offer as well.
And actually, now looking back and see what we are dealing here is only 1% of the patients who have the criteria for bariatric surgery is getting bariatric surgery. That's 1%. So that means there's 99% who's not getting it. So that means, again, I always go with the idea of don't kill the good for perfection. So meaning that when we have 99%, in that 99%, 95% of that is looking for first-time bariatric surgery. And those are people who are suffering from this chronic illness, morbid obesity. So if they can choose anything between gastric sleeve, gastric bypass, band, other things, the options are available. And then this is something that we made it even much easier for those who find the process more difficult. What I'm trying to say here is we have designated case managers who are in touch with you on a daily basis. They make your appointments. They follow up for your appointments. They remind you what you need to do, when you need to do, when you need to sleep, when you need to get up. So they pretty much in charge of your life for the whole process. And that is not something that's common in any of the other programs. So that's why I'm extremely comfortable for what we are offering here for our patients who are looking for this operation. And also, it's a same-day procedure. So you come in the morning and you go home in the late afternoon. So after the procedure, you stay there for 6 to 8 hours, which averaging 6 hours is more these days than the 8. And that's the wonderful thing. So, I mean, life can be complicated. So I have this little eye thing going on. So that's why I'm hiding it with the glasses. But it doesn't go away. So it's with me for 5, 6 days, probably minimum. But after the bariatric surgery, you go home on the same day. That tells you how efficient we made this for our patients. So this process is the best way to find a new life, a new chapter in your life, and hopefully we can be part of it. Dr. Erkan, thank you so much for joining me today. So we'll be back.
Thank you, Kemal. Thank you. Appreciate it.
Of course. So we'll continue the discussion.
Okay.